Hello, and welcome to Evidence-Based Medicine in the setting of Lyme disease. I'm Dr. Betty Maloney, Education Director for VectorWise CME. I've been producing accredited CME programming on tick-borne diseases since 2007, authored several papers on Lyme disease, including treatment guidelines, and I was a member of the 2021-22 Federal Advisory Committee Tick-Borne Disease Working Group. The learning objectives for this course are listed here. I have no financial relationships with ineligible companies, and off-label use of antibiotics will not be discussed. Evidence-based medicine is a term that's frequently invoked when it comes to diagnosing and treating Lyme disease. So let's talk about what EBM truly is. The founders of evidence-based medicine defined it as the integration of best research evidence with clinical expertise and patient values. These elements exist in tension with one another, and the value of each is situational. When the clinical research evidence is strong, as seen here, it is weighted more heavily than clinical expertise and patient values. This is because clinical expertise and patient values would likely align with the research findings. In contrast, when the research evidence is weak, clinical expertise might diverge from trial findings. In such circumstances, the spectrum of patient values may be quite broad. Therefore, when the trial evidence is weak, its value is given less weight, while the importance of clinical expertise and patient values rises. In general, the overall quality of the U.S. trial evidence for making treatment recommendations for Lyme disease is very low to low. That's according to 4-grade or Cochrane-based assessments of the evidence. The fifth assessment used a modified approach and rated the evidence slightly higher. A major problem with the trial evidence is that there are too few U.S. clinical trials to draw strong conclusions regarding treatment. For example, there are only 8 randomized comparative trials for the treatment of patients with EM rashes, and only 4 randomized controlled trials regarding antibiotic retreatment. Some of the language in the older trials and reviews of those trials can be misleading, so a little bit of skepticism as you read may be useful. Being able to judge the quality of trial evidence is an important skill, and all clinicians need a basic understanding of how to read papers that report the outcomes of clinical trials. This is especially important for tick-borne diseases like Lyme disease because the paucity of the evidence means that what is available deserves extra attention to avoid making ill-founded claims regarding treatment successes and failures. Trials can be assessed on these 4 parameters: clinical relevance, trial design, results reporting, and the appropriateness of the conclusions and discussion. You may need to look at each of these to get the full picture of a trial's worth. Assessing for clinical relevance is straightforward. Generalizability deals with whether the trial findings are applicable to community clinical practices. Are the recruited subjects and trial conditions similar to your practice? If not, then the findings don't apply and you can put the study aside. It turns out that many trials that were used to make strong treatment recommendations regarding Lyme disease don't apply. For example, conditions in the single-dose doxycycline trial for antibiotic prophylaxis of a tick bite used an entomologist to judge tick engorgement, a skill most clinicians lack. European Borrelia species behave differently from U.S. Borrelia burgdorferi, so European studies don't apply to U.S. patients. Assessing trial design considers several factors. Design choices are listed in the methodology section of a paper. Did the recruitment criteria make sense for the clinical question being investigated? How were outcomes defined? Were they strictly binary, success or failure, or were there gradations, complete success, partial success? incomplete response, or failure. We'll get to the statistical details shortly. Here's some examples of problematic definitions from the Lyme literature. The retreatment trial by Krupp and colleagues includes an experimental marker of Lyme disease, the presence of outer surface protein A, or OPS-A, in CSF as a primary endpoint, and hypothesized that treatment with IV ceftriaxone would clear it. Because only 16% of the subjects were OPS-A positive at baseline, it would be almost impossible to detect a treatment effect on this endpoint. In the second example, patient outcomes were categorized as success, improved, or failure. However, the improved category was so broadly defined that patients with persistently severe cognitive deficits were categorized as improved because their arthritis improved. That sort of categorization would not go over well in clinical practice. Biostatistical assessments can be pretty detailed, but knowing a few basic concepts and parameters is all you need. The design treatment effect size is a best guess estimate by researchers about how much better a patient should be on a given endpoint in order to say that treatment was effective. Power is the likelihood of finding a treatment effect if there is one. Typically, trials are designed to have a minimum of 80% power. Lower power thresholds waste time and resources because you could miss real treatment effects. The p-value is different from power. It's an assessment of how likely a finding was simply due to a sampling error. The lower the p-value, the less likely a sampling error. The generally accepted cutoff for statistical significance is less than 0.05. N is the number of subjects. The minimal clinically important difference, or MCID, is similar to treatment effect size, but it's the smallest change in a treatment outcome that patients would consider important. In a well-designed trial, the treatment effect size should correspond to MCID. If the treatment effect size is set higher than the MCID, patients in the study may be pleased with their response, but the trial itself might find that treatment was ineffective. To achieve a set power, trials can be designed in two ways. The first is to use a large patient sample size, which allows investigators to find small treatment effect sizes. The second is to use a smaller sample size, which reliably detects large treatment effects. Both methods have pros and cons that need to be considered when designing a trial. Using a large sample size increases the likelihood of finding small treatment effect sizes and may lend itself to subgroup analyses, but it can be hard to recruit sufficient numbers in a timely fashion, so multiple trial sites may be required and costs will be substantial. Smaller trials are cheaper, but increase the risk of a type 2 error, which is failing to find a treatment effect when there is one. A major problem with the U.S. clinical trials for Lyme disease is that they were simply too small. In a pediatric trial on EM rashes that compared amoxicillin to 2 different doses of cefuroxime, the amoxicillin arm had only 13 subjects, and the cefuroxime arms had only 15. The Klempner retreatment trial had 129 subjects, but because it had broad inclusion criteria and admitted a very heterogeneous patient group, it's likely that there weren't enough patients to find a minimal clinically important difference. Most clinical trials follow patients beyond the end of treatment, and the trial design sets out the length of the observation period and the frequency and time points when post-treatment data will be collected. Subjects that prematurely drop out of a study can bias the findings if their reason for dropping out was related to the study. Examples include leaving due to adverse events, or leaving because treatment was ineffective and they want to try something else. Here are the three main ways that dropouts can be handled: intent to treat, last observation carried forward, and complete case. The method must be designated before the trial begins. Regardless of the chosen method, when the dropout rate equals or exceeds 20%, the risk of bias is too great and the trial's effectiveness findings are unreliable. Let's compare the three methodologies. Intent to treat is considered the most reliable because it's more likely to reflect clinical realities than the other two. Subject outcomes are analyzed based on their assigned group, even if subjects break study protocols. Values for the missing data are filled in based on assumptions described prior to the start of the study. In last observation carried forward, the result of the last interaction is used to fill in values for the missed time points. The complete case method does not fill in missing data. Instead, it drops out the subject's data in its entirety. There are potential problems with each methodology. Complete case and last observation carried forward are likely to overestimate treatment success. Complete case doesn't account for patients who drop out due to treatment failure or the inability to tolerate the therapy. And last observation carried forward misses relapses. Imputing values, as last observation carried forward and intent to treat do, adds uncertainty. Because intent to treat counts those who broke protocol, intent to treat may wrongly attribute success or failure to therapy when it may have been due to the use of a non-study agent. This example compares complete case and intent to treat methodologies with regard to treatment outcomes, using the data from Wormser's 2003 study of doxycycline regimens for the treatment of EM rashes. This is the 10-day arm of the study. This study is frequently cited to support the claim that outcomes improve as time goes by. If you look at the percentages, that appears to be true. But this is a mirage. Note that the absolute number of people who were well at 3 and 12 months is the same. The percentages went up because people dropped out, shrinking the denominator. Here's how things play out using intent to treat, assuming all of the missing were failures. The differences are striking at the 30-month endpoint. The actual effectiveness of 10 days of doxycycline falls somewhere between the two values, but it's anyone's guess as to what the true value is. You can examine most results, conclusions, and discussions using common sense. Do the findings seem reasonable? If not, do the authors explain why they are likely valid? Do the conclusions fit with the trial design? Good discussion should address any questions the findings raise and put the results in the context of previous evidence and thoughts on the subject. Therapeutic trials should also discuss safety and feasibility issues. Discussions of acceptable risks are tricky because they are value-laden. Ill people with few or no treatment alternatives may be willing to accept more risk if there's a possibility of getting well. Regarding a study's limitations, do researchers acknowledge weaknesses in study design, methodology, or data collection that may impact the generalizability of their findings? Here's an example of a surprising result. The shorter antibiotic treatment duration outperformed the longer one. Given that antibiotics don't revive pathogens, the author needed to explain the finding. The most logical is that it's a statistical fluke due to low sample sizes. Here's a study to look at, focusing first on the conclusion. We support 2 to 4 weeks of ceftriaxone, but not prolonged courses. And now the design. The conclusion regarding prolonged courses implies that they investigated this therapy, but they didn't. Given that their data is silent about prolonged therapy, the authors should be too. Here's another example. This is from the paper by Nadelman and colleagues describing the trial investigating the use of single-dose doxycycline for Lyme disease prophylaxis following an Ixodes scapularis tick bite. Participants were only followed for 6 weeks, which is too short to determine whether neurologic and arthritic complications were prevented. There were also 3 cases of viral-like illness with seroconversion at the 6-week draw, suggesting these subjects had non-erythema migrans early disease. Taken together, the 87% effectiveness rate is actually limited to prevention of an EM at the bite site. It's important to bear in mind that trials report average responses, but individual patient responses are heterogeneous. Consider the response curve in this diagram. Treatment can be deemed successful for an individual if the response falls to the right of the cutoff value. Success for the group requires that the majority have a positive treatment response. With the cutoff set at A, the majority had a positive response, so treatment would be deemed efficacious. When the cutoff switches to B, most do not benefit from it, and the treatment would be considered ineffective. However, for the folks who fell here, treatment was successful, illustrating the point that minimal responses to treatment in the majority may mask a significant treatment effect in the minority. Here's an example of a significant response in the minority being masked by an absent or minimal response in the majority. It's from Fallon's 2008 Lyme retreatment trial. This study was designed with fatigue as a secondary endpoint, but there were no specific entrance requirements regarding the severity of fatigue. While the group as a whole did not have a reduction in fatigue following retreatment, the subset of people with severe fatigue experienced a moderate to large benefit that was sustained. Recall that when the quality of trial evidence is low, as it is in Lyme disease, then clinical expertise and patient values become critical to the practice of evidence-based medicine. Clinical expertise doesn't arise de novo. It's acquired through knowledge of relevant research and informed by information shared from experienced colleagues. A clinician's personal experiences also add to their expertise. Clinical expertise requires familiarity with potential therapies and the details regarding potential benefits, risk profiles, and situational hierarchy of treatment choices. There's a wide spectrum of patient values and preferences. Health goals are highly variable, as are definition of what constitutes a valuable therapeutic benefit. Patients also differ in their tolerance for risk, with sicker patients often willing to take on greater risk because they have more to gain and/or less to lose. Patient preferences are often shaped by individual realities. Those with greater resources, both financial and supportive, may decide to utilize therapies that are out of reach to others. Shared decision-making is central to patient-centered care. Patient-centered care works toward achieving treatment outcomes that a given patient values. This requires clinicians and patients to engage in a meaningful discussion about the patient's health goals, risk tolerance, and available resources, as well as the available evidence, the risks and benefits of potential treatment options, and the clinician's expertise with each. Shared decision-making is a bit of a misnomer because decisions are not truly shared between clinician and patient. While information sharing, clinician to patient and patient to clinician, is critical to the success of this method, the clinician remains responsible for choosing between options. Just as patients are not obligated to accept what the clinician offers, clinicians are not obligated to provide all potential therapies. Given the often complex and variable nature of treating patients who have Lyme disease, it's necessary for a patient and their treating clinician to have an ongoing conversation as the situation unfolds. In summary, the U.S. trial literature on Lyme disease is sparse and the available evidence is of low quality. Clinicians need to exercise critical reading skills when reading the Lyme literature, as findings are not always clear-cut and are sometimes misrepresented. Under such circumstances, evidence-based medicine promotes the importance of clinical expertise and patient values. Discussions about whether and how to treat require a thorough dialogue between clinicians and patients that is conducted in the context of shared decision-making. Thank you for participating in this module. I hope you found the information helpful.